Good morning, and welcome to the Psoriatic Arthritis edition of Breakfast Briefings. I'm your host, Alan Gabowski, Professor of Medicine at Weill Cornell Medicine and attending rheumatologist at Hospital for Special Surgery in New York. Now, you may be wondering, what is a breakfast briefing? We all know that 2020 has presented many challenges for annual meetings, but even if we were together at the convention center, it could be a logistical challenge to coordinate all the sessions that you want to attend. Not infrequently, your 9 o'clock session is in room A, your 9:15 session is in room Z, and your 9:30 session is in room Q. Good luck with that. CME Outfitters has developed a new way to address the potential fear of missing out with these breakfast briefings. Each morning, I will be providing a brief overview of the best poster or abstract being presented that day in psoriatic arthritis. I'll share the results with you, but also give you my take on why the results matter to clinical practice. CME Outfitters would like to thank Bristol Myers Squibb for their support of this program. To begin our psoriatic arthritis breakfast briefings, I'd like to review abstract 0320, a poster being presented by Gazitt and colleagues entitled Assessment of Implementation of the Treat to Target Concept Using Validated Composite Scores in Psoriatic Arthritis. Well, the Treat to Target concept was initially employed in rheumatoid arthritis, where we learned that incorporating a measurement strategy together with a therapeutic strategy and adjusting your therapeutic strategy based on the measurements of disease activity would result in a better short and long-term outcome. And this concept of treat to target necessitates identifying a target, using a validated clinical metric, and then adjusting your therapy at each visit based on to what degree you're meeting or reaching or heading towards the target that you have established. In other words, you don't just do something unless there's a change in disease activity, and you don't just stand there if disease activity hasn't improved. So now we're seeing the use of treat to target in other areas of rheumatology as well, and in particular now, psoriatic arthritis. This study looked at consecutive psoriatic arthritis patient visits during the period of time 2016 to 2017, and taking into account things like patient demographics, clinical disease parameters, composite scores like the minimal disease activity, the MDA, and the disease activity index for psoriatic arthritis, the DAPSA, medication use, comorbidities, including osteoarthritis and fibromyalgia, and treatment changes, and medical records were reviewed to assess whether treat to target was implemented. In other words, it's not just important to do a metric, it's important to link the metric to a therapeutic decision. What these authors found was that the treat to target approach was implemented in approximately 2/3 of patient visits using the MDA as their metric, and about 55% of patients using the DAPSA as their metric. There appeared to be no correlation between treat to target implementation and patient age, gender, alcohol and tobacco use, disease parameters, and the treatment regimen chosen. Now, this is very important because we learned for rheumatoid arthritis that the treat to target strategy was therapeutically agnostic, meaning that regardless of the therapy chosen, you got better improvement and clinical outcome improvement with the strategy and the metric than with the strategy alone. Physician assessment of disease activity and treatment changes did not correlate with MDA scores in a little over 1/3 of patients, and in about 3/4 of these patients, the MDA status was overestimated because the physicians disregarded patient-reported outcomes, something that we're frequently guilty of. Now, in conclusion, treat to target was implemented in only about 65% of patients. The main barriers being lack of use of validated practical disease activity scores and disregard for subjective patient-reported outcomes. Why is this important? Well, it tells us that in clinical practice, the use of a therapeutic strategy coupled with a disease metric and linking the metric to changes in your therapeutic strategy can achieve a better outcome. But unless you're using the strategy and linking it to the metric, you're not going to see any significant difference. So it's silly to do the metric unless you're going to link it to a strategy. It's silly to use a strategy unless you're going to link it to a metric, because it's not going to provide you with the best possible outcome. Sadly, we in rheumatology are not always using validated disease activity metrics in our conditions, and it's something that we really need to get a better handle on. Join me again tomorrow for a glimpse of what else you need to learn about psoriatic arthritis in ACR Convergence 2020.